Good evening, everyone. This is Dr. Sandeep Sharma here. I hope I'm live now. I'm just waiting for some connections to happen, and then we can start. Okay. So let me start. Before I start with, some of you know me already. Some of us are meeting for the first time. So I am Dr. Sandeep Sharma. I am MBBS and MD Pediatrics from PGI Chandigarh. I am currently the NEET PG and FMG faculty for DocTutorials. And I am also training students at various platforms for other competitive exams related to my subject, that is pediatrics. So at this Clinical Thursday, because it is happening after a kind of cataclysmic which has happened, has been made. Sooner or later, it will be announced. The fine details will be announced. Many of you are panicking. So what I've tried to do is I have taken up a topic which is likely to be very, very important. Now, as per the next one guidelines, there is a possibility that there is a good possibility that you will be getting a lot of questions which will have para and preclinicals embedded as a part of this system. And questions, I have created questions for discussion, which will be covering the must-know topics from, as far as I know, based upon the competency-based curriculum. They will also ensure that your related aspects of biochemistry, related aspects of medicine, related aspects of laboratory medicine are also covered. And of course, we will be discussing these inside-out topics. I have selected 7 clinical scenarios. Each clinical scenario I will be discussing with you. Then I will be discussing the approach towards it and what are the takeaway points from that. And good evening, everyone, those who are joining right now. There are 2 points before I start with the session. First thing, I will be going a bit faster because I have been given only 20-25 minutes to finish off this session. In case there are any doubts, you can post it in the comments. I will be more than happy to answer it. Secondly, you need to listen to it, this entire video. Please save it, whether you are in final year MBBS, pre-final year, or you are intern or going to sit on the next FMG exam. All of you are going to benefit out of it because it's a combination scenario that I'm going to take up here, right? So this will go up on YouTube. Without wasting any time, let me start with the session. And remember, next one, final guidelines are not yet out. So don't go by conjectures. Whatever preparation you are doing, keep doing. Once the mock test is out, once you give the mock test, we will have a better idea how we are going to plan it. And secondly, at DocTutorials, we will be planning. We have already lined up a lot of exciting new things for all of you, especially for those who will be sitting and preparing for next one exam. I will not go into details and stick to the Clinical Thursday for now. I'm going to share my screen. So just a minute, please. Okay, so the screen has been shared. So let us start with the discussion. So this is Clinical Thursday with me, Dr. Sandeep Sharma. So let us start with question number 1. Clinical, look at this question number 1, clinical scenario question number 1. A child came to evaluation of seizures and he was found to have hepatomegaly. His facial features and ocular findings are as shown. Which of the following can be the possible diagnosis? Now, when you are sitting in an OPD, you are an intern or you are taking a case, sometimes you will find these kind of children coming up to you in pediatric OPD. If I am an examiner, I have to create a scenario-based question. I will be putting a question like this. So this child is having a developmental delay, seizures are there. So he is having CNS involvement, number 1. So mark it. Whenever you get a question like this, try to break down what information the examiner is going to give you. So CNS involvement hai, number 1. He is also having hepatosplenomegaly. disorder का feature भी है. So there is liver and spleen involvement as well. Look at this face of this child. Can you see this face? This is the face which is typically coarse facies. So this is a child with a coarse facies, right? And the fourth thing which you can find in this is this so-called cherry red spot. Cherry red spot. Now, what is the most likely diagnosis which is going to fulfill all of them? You have 4 options given to it. Now, if you are able to identify, see, let me be honest. Nelson, what do we do is we first give a proper reading, we make the concepts, and then we remember the keywords. This is how your teachers also know. So for at your level, what you need to know is get your concepts right when you are reading. When you are revising, highlight the key points. So what is this child having? There is CNS involvement, there is hepatosplenomegaly, there is coarse facies, and there is cherry red spot. So which is the diagnosis which is going to fulfill all 4 of these? The common mistake people will make is they will say it is von Gierke's disease or type 1 glycogen storage disorder. No, let us go stepwise. Phenylketonuria is not the possibility. Why? Phenylketonuria will show blonde skin. Just a second. They will show a blonde skin. There will be blonde hair, flare skin, and they will show mental retardation being present, and there is no splenomegaly. So blonde, fair skin will be present. There will be no coarse facies, no cherry red spot, so less likely. Alkaptonuria does not with coarse facies, cherry red spot. Alkaptonuria presents with darkening of urine on standing. Von Gierke's disease is again von Gierke's disease. There is never splenomegaly. Remember, von Gierke's disease. Sorry. Just a second, please. Von Gierke's disease, splenomegaly is never seen. So let me just highlight von Gierke's disease. There is no splenomegaly. Also, von Gierke's disease, there is no developmental delay. Seizures can happen due to hypoglycemia, but there is no developmental delay. And what type of facies is seen? Which is a past AIMS entrance MCQ. Von Gierke's disease shows doll-like face. Doll-like face is seen, not coarse facies, which is the opposite of coarse facies. Doll-like face, cute face. So everything which looks cute may not be that cute. You know from personal experience, it may be suggestive of a disorder in the child. Later in today's session, I will be showing what doll-like faces look like. What are we left with? D answer, that is GM1 gangliosidosis. Cherry red spot can be seen in multiple conditions. But when they are saying developmental delay with seizures, that is CNS involvement, hepatosplenomegaly, coarse facies, and cherry red spot, we have to look at the 4 options, rule out options one by one. The answer here is D, GM1 gangliosidosis. When you get a question, suppose this question comes to you in the exam, you are preparing again, or this question gets asked 1 year prior to when you are sitting in the exam. So hoga kya? When recall session will happen, everyone will teach the features of GM1 gangliosidosis. Let me be honest. Being to get even top rank 1 in your INI-CET, next one, or NEET PG, you don't need to know the details of GM1 gangliosidosis. You just need to identify the clues. How you are going to identify the clues? Let us look at the explanation. So add these explanation points to your notes. So let us start with the discussion. So question number 1, discussion. What are inborn errors of metabolism? They are disorders in which there is a block in the normal metabolic pathway caused by the defect or absence of a specific enzyme, right? Now, when will you suspect IEM? Pata kaise chalega ki the patient is having inborn error of metabolism? These are the pointers given in AIMS protocol. AIMS is the one who's going to make your next one exam. So AIMS protocols are very, very important, especially in pediatrics. So deterioration after a period of apparent normalcy. Second, parental consanguinity. First degree relatives, brothers, sisters getting married, or first degree cousins getting married. Family history of neonatal death is there. Rapidly progressive encephalopathy and seizures of unexplained cause. If seizures occur due to hypoglycemia, it may not exactly be an inborn error of metabolism. Severe metabolic acidosis, persistent vomiting, peculiar odor in urine, developmental delay plus hepatosplenomegaly. And I told you, this is the one which is mentioned. So if developmental delay with hepatosplenomegaly is there in a child, think of one possibility as being inborn error of metabolism. Right now, you're thinking of inborn error of metabolism. How you are going to reach the diagnosis? Look for clues in the question. The clues will be something like this: clinical pointers. First of all, if they say cherry red spot, as somebody rightly said, cherry red spot commonly seen in Tay-Sachs disease. Cherry red spot can also occur in Niemann-Pick disease. Cherry red spot can also occur in GM1 gangliosidosis. GM1 gangliosidosis, Nelson says 50% children are found to have cherry red spot within first 10 years of life. So GM1 gangliosidosis, there are about 8 to 9 causes of cherry red spot. You will be reading in ophthalmology, but these are the top 3 causes which have been asked in all the 3 entrance exam, FMG, NEET PG, and INI CET in various older papers. So remember at least what has been asked so far. Let me be honest again, previous year questions are gold mine for you, but at the same time, for next one exam, previous year topic alone is not going to be sufficient. Read the topics rather than the questions themselves. And if a question does not have an explanation, try to read the explanation from a standard resource. Don't try to take shortcuts if you have sufficient time. More about it, I will be talking in some details later. So cherry red spot, then this is how cherry red spot looks like. Second, if the question is saying core species, you should think of mucopolysaccharidosis as one possibility, Hurler syndrome, Hunter syndrome, Sanfilippo syndrome. So, and second possibility, GM1 gangliosidosis. GM1 gangliosidosis, these two were mentioned, and so the likely diagnosis in the child is GM1 gangliosidosis. This is how core species look like. If the question says child is having cataract, look at what type of cataract is there. If it is oil drop cataract, galactosemia should be a possibility. If the question is saying sunflower shell, Wilson's disease will be a possibility. Then which inborn error of metabolism has skin rashes, alopecia, and eczema, that is atopic dermatitis like rash, multiple carboxylase deficiency, and biotinase deficiency. So both of them are very, very important. See, there are 216 discrete inborn errors of metabolism which have been described with subtypes in each. It is not possible for even people doing DM genetics and metabolism to remember these 216. तो हम क्या करते हैं? हम उतना करते हैं जितना याद रहे. You should eat what you can digest. And for inborn error of metabolism, 5 or 6 important diseases are there, which I will summarize in the end. Read them inside out, plus remember the clinical approaches, and you are done for the day. If a most expected question is going to be asked according to next exam, 60% questions will be most expected ones. So that will be details will be coming from those areas. In addition, they will be asking some approach-based things in your next one exam. So you need to be clinically oriented for those. So skin rash, if they say inborn being suspected and the child is having loss of hair and hypopigmented lesion and atopic dermatitis like rash, तो दोनों में से कोई भी option हो अगर mentioned होगा, that you can safely mark, that will be the answer in the question. If the question is saying hypopigmentation is there, right, it can be seen in albinism as well. The common IEMs I am talking about. Then if the question is saying rhinomegaly is very important. Enlarged, right? Rhinomegaly will be a feature of von Gierke's disease and Zellweger syndrome. Zellweger syndrome is a peroxisomal disorder. Again, very, very important. And then this clinical pointer will tell you what is the likely inborn error of metabolism if you get a question in the exam. Lastly, retinitis pigmentosa, if the question is saying, you should think of mitochondrial defects as the inborn error of metabolism, right? So clinical approach, when will you think of? Number one, what are the clinical pointers and how to apply and reach the answer? This question, this clinical scenario, I have tried to highlight that aspect. I hope I'm clear. Let us move to question number 2. A child was evaluated for mental retardation. All of these are original questions which I have created especially for this session, keeping in mind the next one guidelines which have come. So he had fair skin and blonde hair with blue eyes. Urine showed a typical musty odor. He was diagnosed as suffering from a classic aminoacidopathy. What is the child suffering from? Can you make any guesses? What is the child suffering from? Mental retardation, fair skin, blue eyes, blonde hair. The child is suffering from? Yes, Phenylketonuria, absolutely right. Phenylketonuria. What component is responsible for this musty odor? Is it phenylalanine? Is it tyrosine? Is it phenylpyruvate? Is it phenylacetate? So this is a question which is a combination of pediatrics along with biochemistry. Unless you know biochemistry, you cannot solve this question. End of the day, this type of question will be there in day one post-lunch session of pediatrics. I was seriously, not very happy when I saw the next one guidelines. There are multiple reasons for that. One of the reason is the pediatrics is in the post-lunch session. You all know what happens once you have taken a heavy meal. So whenever next one exam will be coming and those who will be sitting, try to eat a lighter meal, maybe some juice. Don't skip a meal, but try to take something light. Don't go for chola bhatura or a fried thing. Go for something like a curd rice or simply a juice and then sit in the exam. Pediatrics, you get a question like this, you have to apply your brain cells and integrate. Now, this is the thing that you need to remember. In phenylketonuria, there is a deficiency of the enzyme phenylalanine hydroxylase, which has been asked 2 to 3 times in both NEET PG and FMG exam. Phenylalanine to tyrosine conversion gets disrupted, so phenylalanine gets accumulated in excess. This forms phenylpyruvate. Phenylpyruvates get converted into two metabolites, phenyl acetate, look at the double L here, and single phenyl acetate. This phenyl acetate is the one which is responsible for musty, also called as mousy urine odor. So I'm highlighting a very important point here. Ye jo video hai, all those who will be sitting in FMG exam in the coming days, this is going to be useful for you. INI CET November, agar hoga, I feel personally hoga. If it happens, it will be useful there also. And obviously for next one exam, I have tried. See, mock exam is not there. Agar different pattern hoga, we will come out with more things. But right now, please add these points to your notes. Musty or mousy urine odor is due to phenyl acetate. However, if question asks you, old AIMS question, what is responsible for mental retardation? CNS damage is caused by what? It is not caused by phenyl acetate. Phenylalanine excess produces CNS damage. तो यूरिन ओडर का रीजन अलग है, CNS डैमेज का रीजन अलग है, right? So this is what you need to remember. Additionally, phenylketonuria, the topic you will be reading. So phenylketonuria, important topic from exam point of view, right? Let us move further. Because there was a talk about abnormal urine odors, let us try to summarize the important urine odors. First, urine odor that you need to remember, musty or mousy urine odor, phenylketonuria will be the likely possibility. Secondly, if the question is saying rancid, sada hua urine odor, rancid hota sada hua meat. So sada hua meat, purana meat, वैसा odor, tyrosinemia should be suspected. If question is saying cabbage-like odor, methionine defects should be suspected. If they say tomcat urine, multiple carboxylase deficiency. There is an old Jipmer question. When Jipmer used to be separate from INI-CET, the question was inborn error of metabolism having alopecia, skin rash, and abnormal tomcat urine. The answer was multiple carboxylase deficiency. I just told you multiple carboxylase deficiency में alopecia and skin pigmentation problems भी होते हैं. So tomcat urine, multiple carboxylase deficiency. Then sweaty feet, isovaleric acidemia. Fruity smell or sweet smell will be seen due to ketones. It can happen in diabetic ketoacidosis, starvation, and vomiting. Maple syrup urine odor will be seen in maple syrup urine disease. The question arises, maple syrup क्या होता है? Maple syrup is nothing but burnt sugar smell. Sugar को burn करो अगर, तो उसके जैसा smell जो होता है, that is called as maple syrup. So burnt sugar smell is what is seen in maple syrup urine disease. So this is another important area. 2 questions on this have been asked in FMG exam. It is important for NEET PG next one also, but FMG students, please write it down. Please add it to your notes for last minute revision. Let us move to clinical scenario question number 3. Mother complained that her child's diapers frequently turn black when exposed to air. Which metabolic disorder should be suspected in the child? Now, this is an easy question. I don't think anybody would be getting it wrong. Still, I would be interested in seeing how many of you are able to get it right. What is your answer? A, B, C, or D? I can also catch a breath and get some water for myself. So what is your answer? Yes, Anand has answered correctly. Suresh also correct. Abhijit, absolutely right. Med Psycho, absolutely right. Yes, Dr. Urbi, Dr. Priyanka, all of you are getting it right. It is alkaptonuria. Remember, if the question says inborn error of metabolism in which there is darkening of urine or black colored urine, especially on exposure to air on standing, you should suspect alkaptonuria. There are 3 or 4 important points about alkaptonuria that you should remember. Alkaptonuria shows autosomal recessive inheritance. This is the first thing to remember. Absolutely right. Most of you are answering it correctly. Autosomal recessive inheritance. There is a deficiency of which enzyme? Deficiency of homogentisate, also called as homogentisic acid oxidase, also called as homogentisic dioxygenase enzyme. So multiple naam hai iske. This is the enzyme which is deficient. MCQ. Alkaptonuria, dark black urine हम बात कर चुके हैं. Many patients also show a black pigment deposition in pinna as well as in sclera. But remember कि ये बचपन में नहीं होता. It does not happen in childhood. Pinna and sclera deposition usually occurs beyond 8 to 10 years of age. तो अगर 8 साल से छोटा बच्चा है तो उसमें सिर्फ डार्क यूरिन होगा, उसमें पिन्ना का डिस्कलरेशन, स्क्लीरा का डिस्कलरेशन नहीं होगा. लेकिन अगर प्यूबर्टल या पोस्ट प्यूबर्टल बच्चा है और एडल्ट है तो यू विल हैव ब्लैक पिगमेंटेशन. दिस पिगमेंट कैन गेट डिपॉजिटेड इन द जॉइंट्स आल्सो. And many of these children can have black renal pigment stones also. Alkaptonuria does not kill the child, but it severely affects the quality of life. Treatment, you use a combination of nitisinone. Old OP Ghai कहता था, 9th edition used to say vitamin C is effective. OP Ghai 10th edition raises doubt on that. All the latest research says vitamin C role, it is tried, but it is doubtful whether it actually plays any role in the management or not. And this is something which can be a potential MCQ. Remember, कुछ question ऐसे होंगे next one के अंदर 10% question जो कि किसी को आंसर आता होगा. They will check for recent updates. This is the recent update given in OP Ghai 10th edition. Also mentioned in multiple review articles and recent Nelson as well. So add कर लो. पुराने editions के अंदर, पुराने guide books के अंदर it is mentioned vitamin C and nitisinone both are tried. New guidelines, new textbooks say nitisinone alone is effective. Vitamin C itself alone is not effective. And last point, alkaptonuria was the first inborn error of metabolism which was diagnosed. It is an old MCQ. जब मैं आपकी तरह student था, उस वक्त ये question आता था. So first IEM to be diagnosed was alkaptonuria at that time, right? So these are the points related to this clinical scenario. So याद रख लो, IEM with dark urine, alkaptonuria. Let us move further. Clinical scenario question number 4. अभी दिमाग लगाना है, right? Young infant presented with unexplained, पता नहीं लग रहा reason क्या है, poor feeding, vomiting, seizures and hypotonia. These features can be due to inborn error of metabolism. They can be due to infection. So sepsis भी कर सकता है. But sepsis screen was negative. तो लग नहीं रहा कि infection है. Initially plasma ammonia किया, ये देखने के लिए कि urea cycle defect तो नहीं है. But it was normal. Only if it was high, you will think of urea cycle defect, right? What next investigation should be done? अब आप intern हो ड्यूटी पर, आपको इन्वेस्टिगेशन ऑर्डर करना है. क्या करोगे? If you raise on internship or post intern, if you raise your senior resident on duty or your senior JR on duty, they rebuke you. You will know with experience. And many of the senior JRs and SRs, they are useless anyways. They will just switch off their phone, go to duty room and sleep. Now you cannot, you have to be responsible. What test will you order? What test will you order? See, inborn error of metabolism सोच रहे हैं तो abdominal X-ray तो नहीं होगा. Suppose you are sitting in the exam, आंसर नहीं आता, तुक्का मारना है. कैसे मारेंगे? एब्डोमिनल एक्सरे तो नहीं हो सकता, क्यों करेंगे आईईएम के अंदर? एमआरआई ब्रेन भी बिल्कुल नहीं हो सकता. वैसे भी बच्चा स्टेबल नहीं है, अभी इन्फेंट वॉमिटिंग के साथ आ रहा है, हाइपोटोनिया के साथ आ रहा है. एमआरआई रात के 2 बजे कौन करेगा? ये दोनों में से आंसर होगा. रिपीट प्लाज्मा अमोनिया करके हमें कुछ नहीं मिलने वाला. लाइकली आंसर जो हो सकता है वो एबीजी है. लेकिन हमें याद क्या करना है? व्हाट आर वी सपोज टू रिमेंबर फ्रॉम एग्जाम पॉइंट ऑफ व्यू? लेट अस लुक एट what we actually need to remember. And this is a very important table I have taken from latest Nelson. अप्रोच टू इनबॉर्न एरर ऑफ मेटाबॉलिज्म, मल्टीपल अप्रोचेस आर देयर, ये वाला अप्रोच बिल्कुल लेटेस्ट है, तो इसको याद कर लो फ्लो चार्ट को। अब मैं समझाता हूँ फ्लो चार्ट को, मुश्किल नहीं है, सिर्फ समझना है कि न्यूबॉर्न अगर या इन्फेंट, इफ दैट न्यूबॉर्न कम्स टू यू विच इज विद अनएक्सप्लेन्ड फीचर्स लाइक पुअर फीडिंग, vomiting not due to GI anomalies, right? Lethargy, convulsion and coma. So CNS involvement, poor feeding, vomiting, इन सब के साथ प्रेजेंट कर रहा है, तो देयर कैन बी टू पॉसिबिलिटीज, आइदर इट इज अ मेटाबॉलिक डिसऑर्डर IEM में, ये अदर कॉजेज है, इन्फेक्शन, ट्रॉमा, CNS एनोमलीज। अब यहां पर हमने इन्फेक्शन को रूल आउट कर दिया, सो दिस इज लेस लाइकली। तो पहला फर्स्ट, व्हाट इज द फर्स्ट इन्वेस्टिगेशन टू डू, तो एग्जाम में पूछ सकते हैं, सस्पेक्टेड IEM, फर्स्ट इन्वेस्टिगेशन अमोनिया, राइट? यू डू प्लाज्मा अमोनिया इन द पेशेंट। प्लाज्मा अमोनिया करेंगे, अगर हाई मिलेगा तो हम सोचेंगे यूरिया साइकिल डिफेक्ट के बारे में, अगर नॉर्मल मिलेगा तो क्या करेंगे आप? दोनों केसेस के अंदर यू विल चेक फॉर ब्लड pH, कार्बन डाइऑक्साइड एंड बाइकार्बोनेट, एंड विच इज द टेस्ट विच टेल्स यू अबाउट ब्लड pH, CO2 एंड बाइकार्बोनेट? द सेकंड इन्वेस्टिगेशन टू परफॉर्म इज ऑलवेज ABG। सो याद कर लो, अनएक्सप्लेन्ड, अननोन with metabolic defect, first test to do is ammonia, second test to do is ABG, with or without blood glucose। ब्लड ग्लूकोज भी करेंगे, उसका सेपरेट प्रेजेंटेशन होता है। आप जब पेशेंट प्रेजेंट करता है, देखो उन्होंने ऊपर ही लिख दिया नॉट रिस्पॉन्सिव टू IV ग्लूकोज, अगर कन्वर्शन सीजर ग्लूकोज को रिस्पॉन्ड कर जाते तो वो हाइपोग्लाइसीमिक होता, हम इस सब की बात ही नहीं करते। तो अनएक्सप्लेन्ड वर्ड में अगर आ रहे हैं तो उसके अंदर आपका फर्स्ट यू विल चेक फॉर अमोनिया, सेकेंडली यू विल चेक फॉर ABG in the patient। If there is normal anan gap and high ammonia, urea cycle defect is likely. If there is normal ammonia and normal anan gap, no acidosis, aminoacidopathies or galactosemia should be suspected. And if there is high anan gap with acidosis, organic acidemias should be suspected. So examiner is not likely to ask you the diagnosis, they will ask you the approach. And this is the approach in one form or the other, similar approach is mentioned. ओपी गई के अंदर भी एक टेबल है, वो इससे अलग दिखता है, बट इफ यू सी सीक्वेंशियली उसके अंदर भी सेम चीज मेंशन्ड है कि पहला टेस्ट अमोनिया करेंगे, सेकंड टेस्ट ABG करेंगे। प्रॉब्लम ये है कि वी ट्राई टू क्रैम अप द टेबल, रट्टा मारने की कोशिश करते हैं, हर चीज रट्टा नहीं लग सकता है। डॉक्टर बनने आए हैं, सिर्फ एग्जाम नहीं क्वालिफाई करना है, कल को लोगों को ठीक भी करना है, राइट? सो कीप दैट इन माइंड। सी, लाइफ इज ऑल अबाउट बैलेंस, सिर्फ रट्टे से एग्जाम क्लियर नहीं होगा और बिना रट्टे के भी नहीं होगा, तो दोनों में बैलेंस बनाना है। सिर्फ MCQ से नहीं होगा, सिर्फ थ्योरी से नहीं होगा, दोनों में बैलेंस बनाना है। पैसा सब कुछ नहीं है, लेकिन पैसे के बिना भी लाइफ नहीं चलती, तो दोनों, पैसा और हैप्पीनेस और कंटेंटमेंट इन लाइफ दोनों जरूरी है। एंड एंड ऑफ द डे एग्जाम्स आल्सो चेक द बैलेंस दैट यू आर हैविंग, प्री एंड पैरा with clinical. Of course, the question exams are becoming more and more clinical, but some concepts and some approach based upon pre and para clinicals is needed so that you can make the diagnosis in clinical subjects and reach the correct answer, right? So let us move further. Let us talk about the next clinical scenario. We are into question number 5, right? साथ ही करने हमने, so just stay with me for some time. Clinical scenario question number 5. Trust me, 5, 6, 7 बहुत interesting है. Question number 5. Infant presented with progressive hepatosplenomegaly and there was seizures in the child. There is presence of PAS positive macrophages with crumpled tissue paper appearance. Can you see this crumpled tissue paper appearance? X-ray showed metaphyseal flaring. X-ray showing metaphyseal flaring is nothing but what you call as Erlenmeyer फ्लास्क डिफॉर्मिटी। लिखेंगे नहीं, बट ये होता है इसका मतलब, deformity is due to metaphyseal flaring. What is the likely diagnosis? Most of you are answering it correctly, absolutely right. The answer to this question is yes, it is Gaucher's disease. All right, Gaucher's disease, जिन्होंने पास पेपर्स के एग्जाम दिए हैं लास्ट 3 years के अंदर, ये FMG में आ चुका है, ये नीट PG में आ चुका है, और ये 2 बार INI CET में आ चुका है, तो तीनों में आ चुका है, और नेक्स्ट में भी आएगा, राइट? डायरेक्टली इनडायरेक्टली कहीं ना कहीं आएगा। सो बी रेडी विद Gaucher's disease, and that is why I have taken some key points from multiple sources covering all the points that you need to know. So Gaucher's disease, first thing, it is the most common lysosomal storage disorder, right? Second, inheritance is autosomal recessive. Third, the deficient enzyme is glucocerebrosidase. also called as acid beta glucosidase. अगर ये एंजाइम डेफिशिएंट होता है तो क्या होगा? There will be accumulation of glucocerebrosides. One of them is glucosyl ceramide, जो कि डिपॉजिट हो जाता है in the cells of reticuloendothelial system like liver and spleen, and that is why it causes hepatosplenomegaly. It is a type of storage disorder. And patients के अंदर क्या होगा? जब आप चेक करेंगे, बायोप्सी करेंगे इन आरई सिस्टम का, you will find that there will be PAS positive swollen cells with vacuoles. There is eccentric nucleus. Can you see this cell? एक तरफ को पड़ा न्यूक्लियस, crumpled tissue paper appearance है, and इन cells को हम कहते हैं Gaucher cells, right? So foamy, PAS positive, crumpled wrinkled tissue paper appearance cells are known as Gaucher cells. They are the hallmark on biopsy in Gaucher's disease. Now, what are the types and clinical features that you need to know? The first variety is called as type 1, which is non-neuronopathic form. इसमें CNS features नहीं होते, सिर्फ liver involvement होता है, spleen involvement होता है. This is the variety which is most common type. So remember, Gaucher's disease जो कि seizures के साथ आता है वो common नहीं होता. It is the hepatosplenomegaly वाला which is most common. There are no CNS features. Onset can happen at any age, starting from a newborn, sometimes in 20 to 30 year adulthood के अंदर. And hepatosplenomegaly will be there. Bone marrow involvement will lead to progressive pancytopenia. So type 2 will be acute neuronopathic form. This is the fetal or infantile presentation, the most severe form. In these patients, there will be hepatosplenomegaly with forms like seizures and microcephaly. So जो हमने अभी पढ़ा, this question, the diagnosis in the type is, if they ask you the type, it is type 2, that is acute neuronopathic form of Gaucher's disease, right? And then we have death by 2 to 4 years of age. Type 3 is the chronic or juvenile neuronopathic form. ये type 1 और 2 के बीच में कहीं लाई करता है. इनके it is similar to type 1, लेकिन patient के अंदर neurological signs होते हैं, right? And death will occur much later. Death will occur in the second or third decade of life. So these are the 3 types of Gaucher's disease and the related points that you need to remember. Please add them to your notes. क्योंकि अगर Gaucher's disease पे 2 बार 3 बार क्वेश्चन आ चुका है, एग्जामिनर रिपीट नहीं करेगा. Gaucher, he will ask you some more details related to it. People say jack of all trades, master of none. For next one, remember the rule: jack of all trades, master of some. Jack of all trade का मतलब सब थोड़ा थोड़ा पढ़ा, लेकिन जो हाई यील्डिंग टॉपिक हैं, जिनसे ज्यादा चीज आती है, things which are more frequently asked, the so-called things most likely to be asked in the exam, there is 60-70% question वो होंगे, उसके बारे में you should know everything. Follow this approach. More about it, my fellow faculties will be talking about it, I will be talking about it, and you know, time है, panic नहीं करना है. With a cool mind, you have to prepare. For now, just focus on what we are discussing. So next we come to the diagnosis. How you're going to make the diagnosis? You check for glucocerebrosides levels in WBC or skin fibroblast. DNA analysis can be done. X-ray long bones will show Erlen-Meer-Flass deformity due to metaphyseal flaring. This is how Erlen-Meer-Flass deformity of femur usually looks like. So femur is the bone where Erlen-Meer-Flass deformity features are most predominant. Understood? So what is the therapy? Enzyme replacement therapy is available. Question can be asked in the exam, potential question. What was the first storage disease in which enzyme replacement therapy became available? It is Gaucher's disease. अगर पूछे सबसे पहला inborn error of metabolism detect कौन सा हुआ था? Early 1900s में Alkaptonuria. और अगर पूछे therapy available सबसे पहले हुआ, answer will be Gaucher's disease. Both of them are one-liners, but they can ask as one-liner. They can also ask as a scenario-based thing. Next, enzyme replacement therapy is available for type 1 and type 3. Unfortunately, type 2, most of them have a very poor prognosis. 3 variants of enzyme replacement therapy are available. तो यहाँ पर हमारा आ गया pharmacology, new drugs. What are the types of enzyme replacement therapy? Imiglucerase, velaglucerase alpha, and teliglucerase alpha. These are the 3 ERTs which are available. All the 3 are for Gaucher's disease. It cannot reverse CNS abnormalities, so you should start in juvenile neuronopathic forms. You should start it before CNS features appear. Then splenectomy used to be the old therapy. Bone marrow transplant can be tried, and substrate reduction agent. Again, these are the new drugs. So ये मैं pharmacology भी साथ में cover कर रहा हूँ. So new drugs, substrate reduction agent. They decrease the synthesis of these glucosyl ceramide by inhibition of the synthase enzyme. And there are 2 types, miglustat and eliglustat. Are they available easily? Unfortunately not. They are very costly drugs, and imported forms they are available. cost becomes a major hindrance. So these are the therapies related to important for Gaucher's disease. So we have done a quick recap, quick recall of the Gaucher's disease topic. Next scenario, second last scenario. Scenario number 6. Neonate was delivered at term by normal vaginal delivery and cried immediately at birth. Baby was discharged on exclusive breastfeeds on next day. Day 4, he came back with vomiting, poor feeding, and progressive jaundice. Jaundice, neonatal jaundice भी हो सकता है, but vomiting, poor feeding हुआ है. Urine tested showed a positive Benedict's reaction for reducing substance in urine. This is the first clue. Child developed sepsis during hospital stays. Second clue. Blood culture was positive. What organism will be the likely cause of sepsis in this child? So whenever there is a child presenting between day 2 to day 5 with exclusively breastfed child, EBF is exclusively breastfed child, comes to you with vomiting, seizures, poor feeding, and progressive rise in the bilirubin levels, you should suspect the child is having galactosemia. Galactosemia, how will you check for? The screening test is urine. When you do Benedict's test in urine, that will be positive. That will show reducing substance in the urine. Please understand, there is another important concept here. Urine में reducing substance check करने का, there are 2 ways. One is the dipstick method, which uses glucose oxidase agent. Glucose oxidase agent does not detect excess galactose or its derivatives. So that will be negative in these patients. But Benedict's test can detect galactose and its metabolites, and so it will be positive in these patients, right? You find that these patients, although you will find that oil drop cataract has been described, oil drop cataract takes about 1 to 2 months to develop. So child पहले हफ्ते में cataract नहीं है, does not mean the child is not having galactosemia. It takes some time for cataract to develop in the child, right? And which is the likely cause of sepsis? About 80% cases, if sepsis develops, it is caused by E. coli. E. coli sepsis. E. coli sepsis is the cause, right? So let us do a quick 4, 5, 6 points related to galactosemia. A quick summary before we go to the last question. Galactosemia, it is an inborn error of metabolism, which is due to 3 types of enzyme deficiencies. 3 types of enzyme deficiencies. We have first enzyme known as galactokinase deficiency. Second is epimerase deficiency. And third is GALT1 deficiency. What is GALT1 deficiency? It stands for galactose 1-phosphate uridyl transferase. And if they ask in the exam, which is the most common enzyme deficiency, this is the one which is most common. This produces the so-called classic galactosemia. So, अगर option में सारे mentioned है और एक चुनना है, this will be the answer. This enzyme deficiency produces classic galactosemia. So, अब क्या होता है? Mother's milk में है lactose. Lactose leads to formation of galactose. Galactose cannot be digested because this enzyme is deficient. So, on starting, they will be normal at birth, right? On starting exclusive breastfeeding, between day 2 to day 5 of life, the child will present with seizures, hypoglycemia, because he will be unable to tolerate. There will be vomiting, and there will be liver damage leading to bilirubin levels. Initially, it can be mistaken for neonatal jaundice. Level rising, SGOT and SGP will also start rising. And in about 1 month or so, the child will develop cataracts also. Oil drop cataract, a type of nuclear cataract, will be seen in these patients. These children will have hepatomegaly and increased risk of sepsis. And if they say which sepsis is the cause of death, E. coli is vastly responsible. Multiple reasons are there. Galactosemia में E. coli करता है sepsis, unless proven otherwise. यही mark करना है. This is a likely question in your exam. So increased sepsis, E. coli is responsible. And treatment, obviously, in these patients,